Good morning. This is the first webinar for the International Menopause Society, and my name is Wendy Wolfman, and I'm talking to you today from very cold Toronto, Canada. So I welcome all the participants who are going to have a great talk by two unbelievable speakers. And I would like to thank Bessance Healthcare. This webinar has been supported by an unrestricted educational grant from them. Bessance Healthcare has no role in the selection of the speakers or the selection of the topics and has not vetted or reviewed the content of the speakers' presentations. So our agenda today, first of all, I am a professor in the Department of Obstetrics and Gynecology at the University of Toronto. I am director of the Menopause and Premature Ovarian Insufficiency Units at Mount Sinai Hospital in Toronto. And I am the treasurer of the International Menopause Society and the past president of the Canadian Menopause Society. I will introduce first Professor Panay, and he will speak, and then I will introduce Dr. Richard Anderson, and he will speak. And at the end, we'll have questions and answers, which I will field in the question and answer section. Professor Nick Panay is a consultant gynecologist, specialist in reproductive medicine at Queen Charlotte's and Chelsea Hospital, Imperial College Healthcare, the National Health Society Trust Professor of Practice in the Imperial College London, past president of the International Menopause Society, guest professor in Beijing OBGYN Capital Medical University. He's going to talk about premature ovarian insufficiency overview of a new guideline. Thank you, Nick.
Thank you, Wendy. Thank you to BT for hosting this and for the International Menopause Society for organizing this series of webinars, which I trust that people will find very interesting. I am indeed past president of the International Menopause Society. I'm getting used to being past president, having recently handed over to my excellent colleague, Rosella Nappi. And I have, in the next 20-25 minutes, the opportunity to talk to you about what has been essentially a labor of love in developing the updated version of the premature ovarian insufficiency guideline, assisted by my able colleagues. Now, these are my disclosures. So just to give you a little bit of background, the guideline which we updated was the 2015 version of the ESHRA POI Guideline. And this was in collaboration, in partnership with the Center for Research Excellence in Women's Health and Reproductive Life at Monash, the American Society for Reproductive Medicine, and the International Menopause Society. And you can see the cover of the previous and also the new version. These are my wonderful colleagues who were participating in the guideline update, including the next speaker, who will be Professor Richard Anderson, who chaired the steering committee. I was co-chair of the guideline development group with Professor Amanda Vincent from Melbourne. The collaborating organizations, our stakeholders, you can see here, who provided extremely valuable input into the development of this guideline. And really importantly, it included two women's advocacy group representatives, as well as input from other women with lived experience of POI, which really helped us to make the guideline as relevant as possible to POI sufferers. This is a summary of the guideline development that took place. We composed a new international GDG. There was revision of the key questions using input from our stakeholders. And then there was update of the literature searches writing of the summary of evidence, and discussion of the recommendations, which led to the draft guideline, which was then published for stakeholder feedback. Following feedback, there was an approval process where ESHRE EXCO approved the guideline, and it was eventually published online. And you can see there the online version at the ESHRE website. Two things that I'd like to emphasize is that an integrity assessment was conducted for the RCTs on POI to make sure that the studies that we included were as valid as possible and hadn't been retracted. And there were 425 stakeholder comments received from 23 reviewers. 61% of the 374 comments on the content resulted in an adaptation or correction in the guideline text. So we really did listen to our stakeholders. Okay, so these are some of the data from the scoping survey. More than 75% wanted the previous key questions retained. There were 40 key questions in total. In terms of additional key questions or topics, you can see here the ones that the health professionals desired particularly, which is what autoantibody tests should be done as part of the diagnosis of POI, and also on the use of anti-Müllerian hormone to diagnose and or predict POI. And then those questions desired by both health professionals and women, these included fertility preservation, which Richard will talk about, lifestyle management, non-hormonal therapies, and risk factors for POI. So these are the sections of the guideline that we ended up with expanded sections on risk factors, AMH, care of women with POI, and non-hormonal treatments, including lifestyle. And there was also a new section on muscle health. We used the grade system for formulating the recommendations as per ESHRE methodology. The strength of these recommendations, which were either strong, conditional, or good practice point, depended not only on the levels of evidence, which you can see here, but also on the benefits versus risks of implementation of these recommendations, the values that patients and clinicians place on these recommendations, the feasibility of implementation, the acceptability, and also the resources that would be required for them to be implemented. In total, there were 145 recommendations, 92 supported by research data, and 53 good practice points or statements based primarily on clinical experience. Now, I want this audience to recognize that the guideline describes different management options, but it has to be acknowledged that for many of these options, supporting evidence in POI was limited, and that's why we had a number of research recommendations as well. But the wider implications of the findings were that the guideline provides you, the healthcare professionals, with clear advice on best practice in POI care based on the best evidence that we currently have available. So I'm now going to cherry pick some of the recommendations. Obviously, with 140 recommendations plus, it's difficult to cover everything in this short presentation. So I'm just going to cherry pick what I hope will not overlap with Richard's presentation as well. So in terms of what this condition should be called, the vast majority of the GDG and also our stakeholders felt that the term premature ovarian insufficiency should be used to describe this condition in research and clinical practice. It's a condition that's defined by loss of ovarian activity before the age of 40, characterized by amenorrhea or irregular menstrual cycles with elevated gonadotropins and low estradiol. I'm sure this audience needs little introduction into those facts. In this guideline, cessation of ovarian function in women aged between 40 and less than 45 was termed early menopause. But early menopause is outside the scope of the current guideline, although I like to think of POI and early menopause as a risk continuum, and the evidence and recommendations may be relevant to women with early menopause as well. And this is another area that needs better research. So the reported prevalence of non-iatrogenic POI used to be quoted at around 1%, but newer studies have placed this at around 3.5%. And population characteristics such as ethnicity may affect the prevalence of non-iatrogenic POI, with a higher prevalence in low and middle income countries. Approximately 12% go through an early menopause. In terms of the symptoms of POI, clearly a significant proportion suffer from vasomotor symptoms, hot flushes and sweats. But we mustn't forget that perhaps an even larger number may suffer with mood swings, sometimes associated with cognitive problems, mental fog, for instance. There may be insomnia, sexual problems, and fatigue. So it's really important, particularly in women with erratic cycles or amenorrhea, that we don't miss the diagnosis just because vasomotor symptoms are not present. The other thing to bear in mind is that the symptoms may be intermittent and may disappear occasionally due to fluctuating ovarian function. They may vary in severity depending on the different underlying causes of POI, and we know with the iatrogenic POI and surgical menopause, the symptoms can be more frequent and more severe. And some women with POI, the younger women particularly, may not experience any symptoms, particularly those with primary amenorrhea, because they haven't been exposed to estrogen for long enough to sensitize them to the withdrawal of estrogen, which occurs in POI. One of the things that the whole group felt very strongly about was that care for women with POI at diagnosis had to be improved. We need to convey the diagnosis of POI in a compassionate and sensitive manner and provide personalized evidence-based information about the condition and ensure sufficient time for women to ask questions. And so shared decision-making and support for continuity of care is very important in managing POI. And it may be that those individuals will require mental health care support, as well as referral to support groups such as the DAISY Network or the Turner Syndrome Foundation. So essential that this condition is taken seriously and that we involve our patients intimately in our decision-making process so that they are empowered to make the choices that are right for them. Because the main consequences of untreated POI, you can see here, are indeed profound. In addition to the impact on quality of life and mental health issues, there are concerns about hypertension, dyslipidemia, cardiovascular disease, stroke, diabetes, dementia, infertility, osteoporosis, possibly an effect on muscle, and also decreased survival rates. So it's really important that we address these issues in POI proactively and preventively. So moving on to some further recommendations in terms of life expectancy, women with POI should be informed that POI without hormone therapy is associated with reduced life expectancy, largely due to cardiovascular disease. And therefore, hormone therapy is recommended until the usual age of menopause, not only to improve well-being, but also as primary prevention. When the usual age of menopause has been reached, there needs to be a risk-benefit assessment as to whether hormone therapy should be continued. And in addition to hormone therapy, it's very important to underpin any treatment that we advise with advice to reduce cardiovascular risk by avoiding smoking, having a healthy diet, regular, ideally weight-bearing exercise, and maintaining a healthy weight range. Osteoporosis risk factors should be identified proactively and addressed at POI diagnosis. The usual lifestyle things which I've talked about, of course, apply. We need to give adequate hormone therapy, and in order to maintain or increase bone density, we may need higher doses of hormone therapy than are used to purely alleviate symptoms, so at least 2 milligrams orally of estradiol or 100 micrograms transdermally are suggested to optimize bone mineral density. And remember, the longer we delay initiation, the greater the risk of osteopenia and osteoporosis. So it's important to initiate early and avoid non-adherence. And if the combined oral contraceptive pill is used, then a continuous or extended regimen is recommended rather than one with a hormone-free interval in order to avoid bone loss. As far as other pharmacological treatments, which may be important, particularly in women with hormone receptor positive cancers, for instance, we really should work together with advice from osteoporosis specialists, particularly rheumatologists. What about muscle health consequences? Well, POI may be associated with reduced muscle mass, strength and performance, which may increase the risk of sarcopenia. Resistance exercise, which benefits women in usual age of menopause, may also benefit women with POI, although we do require better evidence for that. And we need more data in terms of the impact of hormone therapy and testosterone on muscle health. And this is certainly one of the areas that we're calling for more research. What are the consequences for the cardiovascular system? Again, untreated, there's an increased risk of cardiovascular disease. Hormone therapy has beneficial cardiometabolic effects, which can influence cardiovascular disease risk, and non-use of hormone therapy is associated with an increased risk of cardiovascular events and mortality. And hormone therapy, once again, is recommended until the usual age of menopause, at least. Should risk factors be monitored? Well, the guideline group recommended that all women with POI should have annual monitoring of blood pressure, weight, and smoking status. All women with POI should have a lipid profile and diabetes screening at diagnosis, and thereafter the frequency of measurement should be based on the presence of hyperlipidemia, hyperglycemia, and additional risk factors, or global cardiovascular risk. Sexuality, a very important topic for women with POI, and the GDG recommended a personalized approach using a biopsychosocial model for the impact of POI on sexuality. And it may be that certain individuals will benefit from use of testosterone, so that should be considered as an option in women with POI diagnosed with hyperactive sexual desire disorder. We've got short-term data that certainly look reassuring as far as testosterone is concerned. More data in the POI population would certainly be desirable, not only on sexual function, but also looking at the potential impact of testosterone on other aspects of health, bone, cardiovascular, etc. What about cognition and neurological function? Once again, POI is associated with an increased risk of cognitive impairment and dementia. And this is a particular concern for women undergoing bilateral oophorectomy before the age of 45 years. And Walter Rocker in the Mayo Clinics has done a lot of work in this area. So hormone therapy is recommended in women with POI at least until the usual age of menopause to reduce the possible risk of cognitive impairment and dementia. So this table summarizes the benefits of treatment, and you'll have this to study in your leisure after this webinar, which is being recorded. But you can see there are benefits of vasomotor, genitourinary symptoms, life expectancy, skeletal health, muscle health, cardiovascular health. More data on quality of life and more data on muscle health are certainly desirable. And then there's also potential benefits as well for sexual function, neurological function, fertility treatment, where the use of hormone therapy creates a favorable hormonal environment for fertility interventions. More about that from Professor Anderson, and also the use of hormone therapy in puberty induction. So, as I've said earlier, hormone therapy is recommended until the usual age of menopause. However, it's important to recognize that HRT does not provide contraception. So for those women requiring contraception, a contraceptive regimen may be recommended rather than HRT to provide them with that hormonal support. And in terms of the need for ongoing hormone therapy beyond the average age or the usual age of menopause. Again, this needs to be decided on a personalized basis, carefully weighing up the risks and benefits. What about the risks of hormone therapy? Well, there's no evidence that hormone therapy use increases the risk of breast cancer over and above that compared to women of the same age who don't have POI. However, it is not generally recommended in women with a history of breast cancer, but for women with the BRCA1 and 2 mutations without a personal history of breast cancer, they can be advised that hormone therapy is an option after risk-reducing BSO. And we have data over a few years that are reassuring from that perspective, although longer-term data would be desirable. A progestogen should be given to all women with an intact uterus in combination with estrogen to prevent endometrial hyperplasia and cancer. And the guideline group recommends that the dose of progestogen therapy is increased when higher doses of estrogen therapy are used to provide adequate endometrial protection. So this really summarizes the use of hormone therapy in women with POI with potential higher risks linked to comorbidities. TIC indicates no problem at all. So obviously for women with malabsorption, we should be recommending transdermal. In terms of the orange, this indicates shared decision-making. I've talked about use of hormone therapy in women with the BRCA genes, in women with migraine, hypertension, obesity, prior VTE, and liver issues. Then transdermal therapy can usually be used safely in those instances. And in those women with endometriosis, even after hysterectomy, we need to consider the use of progestogen in order to prevent recurrence. In terms of the contraindications, breast cancer survivors, we have to be cautious, of course, and of course, typically hormone therapy is contraindicated, and also those with established ongoing cardiovascular disease. But these issues should be discussed in an open manner so that women can make informed choices even where there are contraindications. So what about the different options for hormone therapy? Well, there are different estrogens and progestogens which may have variable metabolic and breast risks. So again, we need to try and personalize according to the past medical history of the individuals. It's important that women should adhere to their hormone therapy to get the maximum benefits from this in POI. And don't worry about treating genitourinary symptoms. So, for instance, women with vulvovaginal atrophy, genitourinary syndrome of menopause, with additional topical treatment if the systemic treatment is insufficient, because they may have persistent symptoms that will be ameliorated by topical treatment. In terms of the iatrogenic POI, the guideline group recommends a personalized approach to the risks and benefits of hormone therapy with the iatrogenic POI after gynecological and breast cancer. So this again is a summary of hormone therapy after iatrogenic POI. And in those here that you can see with the tick, so for instance, squamous cell carcinoma of the cervix, it is possible to use hormone therapy because this is not a hormone-sensitive malignancy. Also, POI following hematopoietic stem cell transplantation. For those women with cervical adenocarcinoma, early-stage low-risk endometrioid adenocarcinoma, non-hormonal epithelial and non-epithelial ovarian cancer, BRCA2, 1 and 2 mutation carriers, there needs to be this shared care decision based on discussion with the individual and also the oncology team. It's really important that we're singing from the same hymn sheet, so to speak. And then there are the contraindications, of course, to women with hormone-dependent ovarian or uterine tumors and breast cancer survivors. But again, we have to be very careful about monitoring those individuals and implementing alternatives where appropriate to do so. Again, this table is for reference. It shows you what some of the options are for hormone therapy. You'll be able to study this at your leisure. I think the two things I want to emphasize are, first of all, that you tend to need higher doses for POI because it's more physiological for this age group, and the body identical or body similar progestogens are favored for women with POI because these replicate the physiological environment. And I suppose the global challenge, and this is something that we can discuss, is that the availability and cost of hormone therapy regimens vary immensely from region to region and country to country. And it is very frustrating when we can see exactly what is required for a particular individual and recommend so, but that individual can't access it locally. In terms of monitoring, the guideline group recommends that women with POI should have regular clinical review, addressing individualized risk factors and with appropriate adherence to therapy. And again, you can see the summary there of monitoring, which includes an annual review of adherence to therapy, bone health, cardiovascular risk factors, psychological health, watching out for estrogen deficiency symptoms and increasing the dose of hormone therapy where required. And bone mineral density measurement will be dependent on risk factors and what is found at the initial baseline bone density scan. And we should also involve our colleagues, endocrinologists, cardiologists, psychiatrists in the decision-making process. What non-hormonal therapies are available? Well, HCPs could consider non-hormonal pharmacologic and non-pharmacologic therapies that are effective in peri and postmenopausal women, although evidence specific to POI is lacking. What complementary treatments are effective for managing sequelae of POI? Well, complementary therapy should not be used to replace hormone therapy, as there is insufficient evidence on their effectiveness for prevention of long-term sequelae of POI. And as I've said before, it's really important that we implement appropriate lifestyle management options, even though we would benefit from further evidence in terms of those interventions, such as weight-bearing exercise, stopping smoking, and avoiding or minimizing alcohol consumption. How should puberty be induced? Well, puberty should be induced to progress with 17-beta estradiol, starting with low dose at the age of 11 and gradually increasing over 2 to 3 years. The evidence for the optimum mode of administration is inconclusive. But one thing is clear, that the oral contraceptive pill should not be used for puberty induction. And the GDG recommended starting cyclic progestogens after about 2 years of estrogen therapy or when breakthrough bleeding occurs. The pill shouldn't be used because you don't get as good uterine and breast development with the combined oral contraceptive pill, and metabolically may not be as good as well. Again, this is purely for reference. This is the management algorithm, which you'll see in our healthcare professional and patient materials, looking at what we should be asking about in the history, the examinations we should be carrying out, the investigations, and then considering all of the different aspects of a woman's health, including lifestyle, psychological health, fertility, hormone therapy, bone, heart, and brain health, sexual function, and also genitourinary symptoms. And finally, I'd like to leave you with this summary of how we're disseminating and implementing the POI guideline. The materials are already published on the ASRM, ESHRE, Monash, and IMS websites. Summary papers are now co-published in Human Reproduction Open, Fertile Sterile, and Climacteric. And we're following best practice principles of research translation, dissemination, and international implementation. And you can see here some of the education tools that we're using for healthcare providers and the public, including information sheets, algorithms, active learning modules, an Ask Early Menopause app, and we'll be developing slide sets, including updating the Impart POI slide set. We've already presented some of the information at ESHRE 2024 and the IMS Congress last year, and this year we're planning to present the recommendations and guidelines on POI at the ESG in Riga, at EMAS in Valencia, and at the COGI meeting in Rome. And thank you very much for attending the webinars that IMS produced, particularly this one on POI, where we had over 1,000 registrants. And absolutely, finally, Professor Wolfman, I'd just like to really emphasize that the prevalence of POI is not a rare condition, and therefore should be treated very seriously. The etiology is primarily idiopathic at the moment, but the diagnosis is probably genetic in the majority of those patients. And the more research that's being carried out, the more we're realizing that that is the predominant diagnosis in those that receive the diagnosis of idiopathic. The POI diagnostic process should be efficient and supportive. We should be using AMH to assess ovarian reserve if there is diagnostic uncertainty, and Richard Anderson will be talking about that. Counseling plus or minus ovarian reserve testing and genetic testing may need to be performed in relatives. Again, Professor Anderson will talk about that, as he will the fertility aspects, where oocyte and embryo donation still offer the best chance of pregnancy, and the novel fertility enhancing techniques require further research. Hormone therapy in POIs for primary prevention, not just to treat symptoms, and the treatment options are growing, but POI-specific research is vital. And finally, in those having oophorectomy, the benefits versus risks should be very carefully considered if they're having it before the age of 45. Thank you very much for your attention.
Thanks so much, Nick, for that whirlwind review. And now it gives me great pleasure to present Professor Richard Anderson, who will be speaking on the new POI guideline, epidemiology, causes, diagnosis, fertility, and pregnancy. He's a professor of clinical reproductive science at the University of Edinburgh Centre for Reproductive Health. He was a member of the 2015 SYR guideline group in POI and the current updated version of that guideline. He was also chair of the SYR guideline group on fertility preservation in women. And thank you, Richard, for speaking on this very important topic, which really has been overlooked for our patients. So thank you very much.
Thanks very much for that kind introduction, Wendy, and a great pleasure to be speaking today. And thanks for the IMS too, for organizing this webinar and this series and helping promote what is such an important, as you say, area of work that we still need to work internationally to promote this for our patients' benefit. So I am part of this group that Nick has already given this excellent introduction to, and thanks to him and Amanda Vincent from Australia for their excellent chairing of it, and to particularly Natalie Vermeulen from Esri for her fantastic skills in bringing it all together. So as Wendy mentioned, I was part of the past guideline 5 years ago, in 2015, and it's great to see that the new version has moved beyond just being organized by Esri to being a truly global guideline with support across the world, particularly with the ASRM, International Menopause Society, and the Cree World Organization in Melbourne, in Australia, to help promote it. And one of the things that we built into this, which I think is very important, is using the term premature ovarian insufficiency rather than the previous range of terms that were used, both primary and failure both being used. And indeed, it's interesting to see in the literature how premature ovarian insufficiency has indeed become the term of choice internationally. So Nick's given us a great introduction and overview to this topic, just really highlighting the wealth of subject matter that's included in this guideline, a whole range of topics: musculoskeletal, neurology, sexuality, the whole range of issues that women with this condition that is of relevance to women with this condition. So I'm just really going to cut to the quick and discuss the topics that I've been asked to focus on today, which are specifically the epidemiology and causes, the diagnosis, how that has changed, which is particularly important, and implications and treatment for fertility and indeed subsequent successful pregnancy. So one of the things that we were all essentially, those of us of a certain age, were brought up on is actually illustrated here in this slide, where we were always used to be told that the prevalence of POI was about 1% of the female population. And you can see here, this is the slide that comes from, going back now to the mid-1980s. But actually, more recent data has looked at this more critically and updated it, and it does suggest that this is actually a substantial underestimate of the true prevalence of POI. And indeed, nowadays it's recognized that even if you exclude iatrogenic menopause, which is perhaps the biggest single cause, you're still talking about of between 3 and 4% of the female population have this condition. And that rises to about 12% in women with an early menopause when that occurs at the age of 40 to 50 years old. And there's some interesting geographical variations this, with it being probably higher in low and medium economically developed countries. It's perhaps rather sad to still think that even nowadays, and perhaps this will be a surprise to some of you, that actually bilateral oophorectomy remains the commonest cause of POI in Western countries. This is the main part of the some 11% of POI that is iatrogenic. One would hope that might be declining, but the other causes that are iatrogenic probably are not, and are probably going to be increasing. This includes particularly in cancer survivors, where it's very widespread, and we're of course seeing many more of them than we used to. But also after treatment for other conditions where stem cell transplants is used, and this is a very big and growing area, all sorts of conditions, rheumatological, dermatological, as well as hematological, that are being treated with this approach to therapy. And so that's a growing area. And there are other ovarian surgeries as well, and particularly I think relevant here is the treatment for endometriosis, which we're certainly seeing more of in the context of POI. The second big cause is, of course, the autoimmune, and their Addison's disease is the main cause, the main issue for our patients' health, indeed a life-threatening issue that we need to remain aware of, that this is not a trivial implication of this condition. And then Nick's mentioned the genetics, and this is another huge area of growth from the research area. And I'll come back to that in a minute, because we focused very much historically on the monogenic causes and trying to identify, what is that key gene that causes POI. And we're now seeing a different approach as well, with more pictures of patterns of gene change, networks of genes, particularly relating to DNA damage. And I'll show you just a little bit of data about that in a minute. And this, of course, relates to the well-recognized family history that's often the case in this condition. And that's important, not just for the etiology, but for the implications for relatives. And again, I'll come back to that in a minute. So what can we do about it? What can we advise our patients? Well, I think the main thing here is to think about where iatrogenically we may be causing that as healthcare professionals, and to either mitigate that by changing our surgical practices, or potentially by offering fertility preservation interventions. And there may be lifestyle factors as well, such as smoking, that we can influence either individually or through public health measures. And one hopes that over time, there may be changes to the treatment of these serious conditions that is such a risk factor for our patients, that maybe that will be changing. But that's, again, at the moment, it's about identification of risk and identification of patients where fertility preservation may be relevant. So we feel these are all important areas, that the guideline group feels these are all important areas for patient identification and counselling of these risk factors. When you see them in a patient, these are things to bring into the consultation. Just to touch on the genetics, this is a research slide relevant to this, and highlights some of the areas in which this field is progressing. And this is an amazing study of 200,000 women who had their genome analyzed, a GWAS study, highlighting that from this you can identify a genetic score for age at menopause, and indeed going into early menopause and POI beyond that, to generate this genetic score. And many of these genes are related to DNA repair. So you can see here percentage of genetic risk against risks for menopause under 45, showing this really linear relationship across this score, and indeed here for odds ratio for POI and the graph on the right here, this relationship, although of course with more wider error bars reflecting the smaller numbers of women involved in that. So an interesting aspect is not just monogenic genes, but polygenic gene scores is where we're going to be seeing progress in this in the future. What about the diagnosis? Nick has given us a very eloquent and erudite discussion on really recognizing these important symptoms of estrogen deficiency in women presenting with irregular or absent periods, oligomenorrhea or amenorrhea. And this slide highlights the range of symptoms one should be aware of that might be relevant in a woman presenting this. And really, it's a matter of HCPs considering this diagnosis at the top of their list of a woman, how high on their list of a woman walking into the clinic with these symptoms of menstrual dysfunction and potentially estrogen, and looking out for it in a very proactive way. The diagnosis biochemically is still around FSH measurement. In the previous version of the guideline in 2015, we suggested, as had long been the clinical practice, that FSH should be measured twice to confirm the diagnosis. And a lot of that was based upon, this is such a serious, often life-changing diagnosis for women that we wanted to really get it right. But it is also the case that delayed diagnosis or patients not being told the diagnosis when in fact it really is clear in retrospect is a significant problem. And we felt there's really no need to repeat that FSH measurement if the clinical picture is consistent and the first FSH measure is also clearly confirming that diagnosis. So if you have a history of several months of amenorrhea, the woman has an FSH level of 35, 40 or thereabouts, you know what the diagnosis is. There is no need to repeat it. And indeed, repeating it may give you an apparently more normal result that indeed serves to confuse rather than to enlighten. So do it once. If it's clear, that's it. We haven't changed the threshold for that diagnosis for FSH level. It's still 25. In the previous version, this was argued that it was above the level you would ever see in a normal woman, even at the highest that it is in the physiological state, which is at the time of the mid-cycle surge, when you do get a rise in FSH as well as LH. And you should never see a level of 25 in a healthy young woman. Other groups have come to other guidance. There is really probably, other than the argument I've just given you, a lack of other really robust validation. So we feel that 25 is a good number to stick with. The evidence for the hypoestrogenic level being confirmed biochemically is perhaps even weaker and less robust. The American College come up with a useful number that I think is worth bearing in mind of 50 picograms per mil or 184, so a bit under 200 picomoles. And that's really just to make sure that the time you're measuring FSH, there isn't an unexpectedly high estrogen level from a follicle that just happens to have grown up at the time you happen to be measuring that sample, that artificially depresses the FSH level. So if you have a lowish estradiol, below 200-ish in picomoles, and your FSH is high, then that's the diagnosis. It doesn't need to be repeated. We've all seen many, many cases where follicular activity does resume sporadically, and you can have intermittent ovulation, and that can artificially change the biochemistry. So just to re-emphasize that then, it's very clear from our discussions that a single measurement of FSH in a woman with an appropriate history is all one needs to do. You don't need to worry particularly about the estradiol level. It's not a diagnostic criterion, but it's a matter of ensuring it's in the right ballpark to appropriately interpret the FSH level. So there's an awful lot of interest, of course, as to whether anti-Müllerian hormone, AMH, may be of value in this context. And a bit of research, although actually surprisingly in the context of POI, there is perhaps less literature available than you might expect. This has in fact been around for quite a while, this concept, going back to this study from the Netherlands back in 2002, when AMH was proposed to be a marker of ovarian aging on the basis of this steady decline in AMH that you see across the reproductive years, which is more consistent within individuals than the rising FSH that you might see across the later reproductive years, or indeed the decline in follicle count. They are more variable and less reliable. So is this useful? Well, I think we need to remember that in POI, we're talking about depletion of non-growing as well as growing follicles. And of course, we don't have a biochemical marker of the non-growing primordial follicle pool. That still remains an elusive holy grail that we would all love to have, but we do not have at the moment. So AMH is only an indirect measure of that. But it does have advantages because it's not fluctuating across the cycle like FSH and estradiol are, really reflecting these bigger follicles and that endocrine feedback that's so important in regulating monoovulation. So AMH is a better potential marker, but it's not perfect in terms of just identifying the primordial pool. But is it useful? Well, there is a little bit of literature that suggests it, but overall the conclusion is that it really doesn't add in this context. So we have studies such as this very nice one from Germany for a number of years ago. It's a cross-sectional study rather than a longitudinal study, but you can see how in women at progressively more advanced stages from normality to POI, AMH levels are progressively lower till they're almost all very low in women with established POI, but not always. And some occasionally will still have a relatively preserved AMH level, even in the presence of frank POI with amenorrhea, that high FSH level, a robust diagnosis. So it doesn't seem to be of value in replacing that current biochemical analysis. It might be of value if there's diagnostic uncertainty. And this is data from a study that Raymond Lee and from Hong Kong and I did actually a number of years ago, showing how AMH does distinguish from controls, and very much so from women with the other common cause of oligomenorrhea, i.e. polycystic ovary syndrome, with a very good diagnostic cutoff between them. But this is not a prospective type analysis, and indeed there are not adequate prospective analyses in the context of POI that really can inform decision-making using this at the moment. But it may be useful, others it may be misleading, and often sometimes in autoimmune POI, AMH particularly can be relatively maintained even when FSH is high, estradiol is very low. So it can be confusing as well. There are some prospective studies in women with normal or early menopause that suggest some value in looking at this, and this is certainly very interesting data. But the conclusion from this study, for example, or the SWAN study that looked at women of the normal menopause, is that AMH only becomes accurate very, very close to the menopause or in later reproductive years. So you can see here in women under 35, the area under the curve, the C-statistic, is really not terribly strongly diagnostic and only becomes so at age 42, which is, of course, by definition, no longer POI. So overall, the picture here is still that this is a work in progress, and at the moment, it's not a first-line diagnostic test for this condition. So that was our conclusion, that AMH should not be a primary diagnostic test, but may be of use sometimes where other tests are conclusive or the picture is misleading or confusing for one reason or another. And likewise, in terms of prediction of POI, the evidence that it's sufficiently accurate for clinical use is not there. It should not be used for clinical prediction in this context. And indeed, it lends itself very much to overinterpretation and unnecessary worrying of our patients, when actually the literature suggests that many of those women will not go through such an early menopause as you might think. What about other diagnostic tests? Well, chromosome tests and other genetic tests, these remain very important for the establishment of the etiology. A chromosomal test is recommended for everyone. Likewise, a test of the FMR1 mutation, the gene that causes Fragile X syndrome, recommended to be universal and indeed not based on the patient's age, which I'm sure has been some people's clinical practice in the past, but this is thought to be across the age range, equal access. Novel tests, this is where it becomes more challenging because it does vary according to availability from different countries and different parts of the world. And where it is available and there is appropriate genetic counseling, then that may be valuable. But the guideline group didn't feel it was sufficiently universal and sufficiently established to be a strong recommendation. So that's very much conditional on local circumstances. Nick highlighted that antibody testing was an important question raised in the initial scoping survey. And our conclusions were that, yes, indeed, it's very important to test for 21-hydroxylase antibody, the adrenal autoantibody, to be particularly looking for that coexistence with potentially serious Addison's disease. Other antibodies, though, not. There isn't a good test for ovarian autoantibodies, so although it's available, it isn't reliable, so that's not thought to be worth doing. And thyroid peroxidase antibodies also widely tested for, but actually they're so prevalent in the general population that, again, we did not think this was of value to look robustly for an autoimmune etiology in a woman with POI. However, testing thyroid function, absolutely, that is useful, and that should potentially be repeated if there's relevant symptoms later on. Whereas the other antibodies, the adrenal antibody, a single test is thought to be sufficient for identifying that. So that's what I've just said. If this is negative, there's no option, no indication for retesting unless the specific clinical situation, and likewise with thyroid function. So this leads us to this very helpful algorithm that I think is useful to just have in mind when one's working through this diagnostic situation. You have the clinical and biochemical testing here, going on to the fairly, usually generally fairly obvious iatrogenic causes, then genetic testing and autoimmune testing. And if all of that comes out negative or is not present, then one is left with a diagnosis of idiopathic POI. And as Nick highlighted, maybe over the years, that group will more and more be subsumed into the genetic causes, but not so much at the moment. You'll also notice here the importance of considering an effect on relatives, because this is often where the real consequence of that genetic testing is. It's not so much for the individual, it's for their sisters, nieces, other relatives. And we have a specific section on this in the guideline that I think is useful to highlight the importance for other family members, discussion that they are at risk, that they should be aware of what the symptoms are, and that they should seek testing if they develop those symptoms. And there may be a place in some situations where looking at that individual's risk and considering either family planning, i.e. planning a family rather than contraception, or indeed fertility preservation may be of relevance to some of those individuals based on their individual circumstance. So I think this is a really important new aspect of this guideline that deserves consideration and wider clinical practice. So that brings us to fertility. And actually, this is where things really haven't changed greatly since the last guideline, despite actually a wealth of related research has yet to really come to fruition. It remains the case that some women with this diagnosis will conceive. Historically, we've always thought of that being in the order of about 2.5% to 5% of women. It varies according to the design of the study that looks into this. But actually, a very nice French study recently highlighted that women who are younger at diagnosis and women with a lower FSH at diagnosis actually are, perhaps as you might expect, more likely to show some resumption of ovarian activity and therefore a chance of pregnancy. with that chance going from only about 3.5% overall up to perhaps 15% in those younger women with a less markedly elevated FSH diagnosis. So that may be of value for some patients. But within treatments, the question is, what can we do about this? This is such an important part of the initial consultation, and such for many of our patients, and I'm sure that for many of you, this becomes part of a number of consultations rather than just a one-off, isn't it? It's a matter of building on this over time with many of these young women who will be very upset and indeed devastated by this aspect of the diagnosis. Conversely, of course, it does highlight the needs to bring up the idea of contraception if not falling pregnant is the key requirement for your patient at that time, because an unwanted and unplanned pregnancy in this situation is really not going to be a good situation at all, a very, very bad place to be. So we still have egg donation as our #1 effective therapy. And this slide shows the first report of it. And you can see it was in 1984. So this has been around for a long time. This is a very well-established therapy for women with POI. And it remains effective and safe and a source of huge joy to many patients who are able to have a family through this. Otherwise, one of the aspects of this that's important is the donor, and patients may well consider thinking of bringing along a sister or another relative to be the donor, and that can be lovely, but it also raises this issue of shared genetic risk. And there's established data in the literature showing that where sisters are the donors here, they have a higher risk of cycle cancellation due to a poor response, and of course that has serious implications for the sister as well as for the recipient, your existing patients. So this is something that needs to be considered prospectively prior to embarking on a close relative acting as a donor. There is a wealth of literature or research trying to improve on this rather desperate situation, because of course for many patients egg donation is not far from their #1 choice. It's going to be impossible for many of them. So there are all sorts of things looking at in vitro follicle activation, administration of mesenchymal or other stem cells, or particularly injection of platelet-rich plasma into the ovary. And this literature very much swirls between POI and women with advanced maternal age, decreased ovarian reserve, that whole medley of the IVF poor responder, as well as women with established POI. And unfortunately, much of the literature, although apparently identifying positive effects, is really not robust in terms of the controls and the study design that would really underpin these becoming established therapies. So they are not known to be established therapies at present. Just very recently, actually, there has been a proper RCT of platelet-rich plasma published. At the time the guideline was being finished, the abstract had been published, and so that is referenced in the guideline, but the full paper came out just afterwards, and that is here from Emery Semley and colleagues, where 83 patients were randomized to PRP injections into both ovaries a month before IVF treatment. But this is women with poor ovarian reserve, not established POI, I should emphasize. But essentially, they found no embryological or pregnancy positive result here, nor did they find that their ovarian reserve markers were influenced by this treatment. I don't think this will be the end of the story. People will say, well, you should have done this way, not that way. There may be others, but I think this now sets a marker that we now have a well-designed RCT in this field, although not directly for women with POI, as I say, that sets the bar for the standard of scientific research that needs to be done in this field. So what can we conclude from this? Well, we can conclude that for women with established POI, unfortunately, fertility preservation is not a realistic option. It's too late, but it's terribly important for women who are at risk of POI, and particularly at risk of iatrogenic POI, where there is an identified risk to them that something is going to happen to them, they're going to get such and such a treatment that is going to give them a risk of POI, and that is the time for effective fertility intervention at that point prior to that therapy or surgery that's going to be putting them at risk. Should they fall pregnant, let's just think a little bit at the end. This is my last section about the obstetric risks. Well, for most women who fall pregnant after POI, the obstetric risks are low, but there are certain exceptions to that. And that includes egg donation pregnancy, where it's important for the woman and her partner to disclose that this is an egg donation pregnancy to their antenatal midwifery obstetric carers. And there may be other specific conditions as well, and that includes women who've had radiotherapy to the uterus, or, of course, Turner's syndrome, as we well know, carries substantial obstetric risks to both the pregnancy in terms of prematurity and the mother herself as well from a cardiovascular risk. So just to finish with this, one of the things included in the guideline is what I hope is this helpful table, which suggests a number of pre-counseling interventions and investigations for women, and identifies for which women these are relevant and therefore for which women they're of less relevance. And you can see, for example, Turner's is important to do a very full evaluation, but others where there might be, for example, idiopathic POI or autoimmune POI, there is less that needs to be done. So I hope this will be useful in guiding focused intervention and investigation. So I just want to finish by saying this is really just a snapshot of so much else that's in the guideline that is of value, I hope, to all of you in your clinical practice. And as Nick has already highlighted, there are various aspects of dissemination here, and including the Ask Early Menopause app, which is a fantastic resource that patients can download and go away and read at their leisure and really benefit from as a really robust and informative expert tool to help them navigate this difficult condition. So my thanks to you for listening, and Wendy, back over to you.
Thanks a lot, Richard. So I think we have time for a couple of questions. And the first one is, do you have to measure levels of estrogen in women who have POI in order to get the maximal benefit for bone and possibly cardiovascular assessment? So I'll ask Nick.
So this is something that we discussed very carefully in the GDG. It was our feeling that the evidence didn't support routine testing of estradiol levels, and that it really should be considered on an individual basis. In terms of quality of life and well-being, the treatment needs to be sufficient to optimize their well-being, and you don't need a blood test to tell you that. If there are side effects or if there is an inadequate response, that's where an estrogen level may be helpful. In terms of concerns about bone, yes, there is a dose-response effect. And in those in whom there's a particular concern about low bone density, and perhaps they're not able to tolerate higher doses of hormone therapy, there may be some value in testing the levels to make sure they're getting adequate response. DEXA bone densitometry can also help to guide whether higher levels of hormone therapy are required. In terms of cardiovascular, the evidence really isn't there to say that the cardiovascular benefit is achieved at a certain level and not at another level. So I think that really sort of summarizes the situation. That's not to say that we wouldn't benefit from studies where perhaps we can define a sort of therapeutic range going forward that will help to guide people. But those are the thought processes, I think, that need to be considered in determining whether an estrogen level is performed.
Richard, if you had a patient with apparent iatrogenic POI who asked about testing for autoimmune oophouritis, Would these be detectable years after POI onset? And would you even do it? And where do you do it? And how much does it cost?
Yeah, so I don't think measuring autoimmune ovarian autoantibodies are worth testing, Wendy. You know that it isn't going to change your management. You know, we need to focus on the tests that are valuable, and that's particularly the adrenal antibody testing. It's often done. Yeah. I just, you know, it's one of these things where it says it's a test and therefore people believe it's useful, but actually, you know, it's not. You know, if you've said send off some tests and we'll give you a random number generator, people wouldn't do it, and I think we should consider it in that context.
Okay, a couple more questions. Recommendation was made to order BMD if indicated. So isn't POI alone still considered a sufficient risk of osteoporosis that all women should have a baseline DEXA?
It is, and that was part of the update of the recommendations that we do recommend a baseline DEXA scan. The frequency or intervals of subsequent DEXAs will be determined by that initial finding and also the clinical scenario. But absolutely, in an ideal world, all women with POI would have a baseline DEXA. But we're also mindful that globally there can be difficulties in accessing DEXAs in some regions of the world, in which case other parameters need to be taken into consideration. But where available, it should be performed.
And can you just
If I could-
reiterate definition of osteoporosis in young women on a DEXA?
Well, so there was quite a lot of discussion about this in the past, and it used to be said that we should be going by Z scores in the below 40 population. But more recently, definitions for POI have aligned with those of women at usual age of menopause, that we should use T scores as well in determining the risk of osteoporosis. So now we pay at least as much attention to T as we do to Z scores.
Is that reviewed in the guideline or is that something new?
Yeah.
Yeah, okay. In those with POI and dense breasts, are there any good evidence about risks of estrogens and progesterone?
No, the data really aren't there for women with POI. Obviously, breast density is something that's taken into consideration when prescribing at usual age of menopause. And perhaps in a younger population, that should also be taken into account. But generally speaking, younger women have more dense breasts anyway. So we don't recommend routine mammography in women with POI unless they have an increased risk anyway. So from in terms of their family history or personal history or whatever. So perhaps this comes less into the sort of consideration of whether that is a factor that we take into account when we're prescribing, unless there are other risk factors.
Is there any evidence for sequential hormone therapy over continuous combine in young women?
Yeah, not so much in POI. I mean, we've got observational data in older women that sequential may be associated with a slightly lower risk of breast cancer, but that doesn't apply to the POI population. In terms of guidance for you, for which regimen I use, I normally recommend using a sequential regimen at the initial diagnosis, and also if those individuals want to maintain the possibility of achieving a spontaneous pregnancy, which can occur on hormone therapy. If after a few years they wish to switch to a no-bleed regimen, fertility is not an issue, then of course that is something that we will then implement for them.
Are the doses of progesterone and continuous combine enough to inhibit a possible ovulation, Dr. Anderson?
Yeah, as Nick just indicated, in conventional doses of HRT are not contraceptive. So they are not going to be doing that. So as I mentioned in my talk, if not getting pregnant is the priority, then that would be an indication for continuous combined pill administration as a contraceptive and giving you the required estrogen. But as Nick said, HRT, traditional HRT, is perhaps preferable when someone wants to keep open that chance of conception while still ensuring adequate estrogenization.
Is there differences between continuous combined and sequential?
For contraception, gosh, that's a good question. I'm not aware of any robust literature on that, of course, because we know that neither of them are very good contraceptives. So it would be a challenging trial to set up in women who are intrinsically fertile, wouldn't it? I would like to try and get that through an ethics committee. So I think that the discussion there is really what Nick has said, is if you want to fall pregnant, then HRT and a sequential would probably be sensible. If you definitely don't, then conventional birth control is important.
Yeah, and I also find that in younger women, they often want to menstruate to be similar to women of the same age. What are the...
I also find that in some of these younger women, that although some would prefer perhaps to be amenorrheic, the continuous combined regimens can be challenging in terms of irregular bleeding, whereas a sequential pattern can be more straightforward in that regard.
What are the hormone therapy options for patients who are Leiden heterozygous mutation?
Well, I would recommend transdermal. They're not as high a risk, as at higher risk of thrombosis as a homozygous, but still being cautious, I would recommend a transdermal delivery of estrogen. And also in terms of the progestogen, there is some evidence of a lower risk with body identical progesterone or body similar progestogens like dydrogesterone.
With women who had endometrial cancer, early stage, would you prefer to give an E+P or just estradiol replacement therapy?
Sorry, Richard, did you
Someone who
want
had
to kick off?
endometrioid adenocarcinoma early stage, who's using
And has
hormone
had a
therapy.
hysterectomy.
Yes. And needs hormone replacement therapy, who's young, let's say they're 38 or 37. Would you add the progestin or just give them estrogen alone?
The evidence is that adding a progestin doesn't make very much difference, although absence of evidence is not evidence of absence, as I like to say. But there isn't a necessity to add a progestogen unless there was a concomitant diagnosis of endometriosis. They can have estrogen alone. You know, with early stage endometrial cancer, there doesn't appear to be an increased risk of recurrence with either regimen.
Is there a difference between estradiol or estetrol containing continuous combined oral contraceptives in terms of outcomes? Do we even know?
Interesting
Richard?
question. I guess that the data are still are still awaited on that. It's such a new product, really. We don't have a lot of experience of that.
Is there any data on placental stem cell therapy for POI?
Well, there are certainly a lot of publications related to it. The issue is that many of them are not terribly robustly designed. And in our review of this, we really found that there was no robust evidence that these were appropriate therapies to be pursuing at the moment. And I think that was a really clear conclusion of this group, that these therapies really do not stand up to scrutiny at the moment.
For women with secondary amenorrhea after chemo, would FSH tests still be recommended to confirm POI before hormone therapy is initiated?
Yes, I would. I think that under any circumstances, if you're going to make the diagnosis of POI, then you need to go through the standard tests. I'm sure many of us have seen women with amenorrhea that was actually a result of hypothalamic amenorrhea after cancer treatment, for example. So just as you assume a teenager who's a ballet dancer hasn't got functional hypothalamic amenorrhea, likewise after chemo, don't assume POI until you've shown it.
Testosterone is having a huge popularity moment. Everyone wants to be on it. Is the evidence leaning towards more testosterone supplementation in POI or early menopause? Um, do you only prescribe it in women with HSDD and POI?
Yeah, in the absence of good data, the indication in POI as it is for usual age of menopause is HSDD. Um, Again, it's an area that we need more research in, not just for the potential wider benefits of testosterone, but for HSDD as well in women with POI. Yeah, it's an area I know that Professor Vincent, Professor Davis in Australia are starting to look at that issue in a younger population. But at the moment, it is the same indication. And yes, there has been a lot of media hype about it, but I think we need to be cautious about that because we need to follow the evidence. And whilst, yes, some women do have a bit of a light bulb moment when testosterone is given, there are also others that don't respond. And if we elevate expectation levels unrealistically, then it can lead to disappointment. And also, we lack randomized controlled clinical trial data for long-term use of testosterone in this population.
Also, the therapies that we have currently in most countries are male products reduced for women. So we don't have,
Another,
except in
yeah,
Australia, an approved testosterone.
another frustrating aspect about testosterone therapy. So there is more of a margin for error in terms of the dosing.
Can you interpret AMH in an adolescent girl?
Uh, that's an interesting question. It depends a little bit on the context. If you're talking about in an adolescent girl where you think they might have POI, then one would go through the normal criteria, but one would expect their AMH levels to be very low. But I think perhaps the important part of that question is that during adolescence, AMH levels often rise across those years, the teenage years, perhaps on average peaking at about age 24. So one would need to take that into context. But I think that my general comments about, and the guideline group's general comments about AMH generally for the diagnosis of POI apply at all ages.
What would you do with a patient who presents with characteristic symptoms of POI, but the FSH is normal and they can't test for AMH? I assume she had amenorrhea or oligomenorrhea.
I think if the patient has amenorrhea and a normal FSH, one needs to consider what the alternative diagnoses are. But if they have a lot of vasomotor symptoms, then that would certainly be a situation in which repeated measurement would be appropriate. Because of course one can have intermittent restoration of ovulation after a period of amenorrhea for a few months. And under those circumstances, the FSH may relatively normalize. Whereas historically it might have been high, it then goes through a period of relative normality and then goes high again. So that would perhaps be a situation where ongoing monitoring would be perhaps appropriate if the clinical picture very much supports POI as the diagnosis.
Can I make a comment as well? Totally agree with what Professor Anderson has just said. Just to really add that fluctuations in hormone levels can sometimes trigger vasomotor symptoms. So what I would like to know is whether there is a cyclicity to these symptoms, because it can be a feature of premenstrual symptoms. And sometimes I think the question which I was looking at in the Q&As asks whether there might be a benefit to using hormone therapy. There may be, but it's in a different context. It's not to replace hormones that are absent, but to stabilize the hormone fluctuations which are triggering the symptoms. So very interesting scenario.
How does a person diagnose POI in someone who started oral contraceptives or HT who was menstruating but presents with perimenopausal symptoms? And how long do they have to stop their oral contraceptive before FSH is accurate?
Yeah, so it's often the case, isn't it, that a woman will stop her contraceptive pills and will be amenorrheic, and then the diagnosis of POI will emerge when it was effectively masked when she was on treatment. I don't think I think it's difficult to detect it reliably. We don't have a set of diagnostic thresholds for women who are taking different hormonal medications. But one, I don't think you would need to stop it for very long for that FSH to become high. I'm not aware of any literature that's addressed this robustly, but by the time a woman has vasomotor symptoms and it's a few weeks, even just a few weeks after stopping the pill, then I think the diagnosis would be apparent. Yeah.
And one last question. What about the safety of hormone therapy for non-epithelial ovarian tumors?
Look, I think in making a decision about prescribing with ovarian tumors, as with other scenarios of malignancy, it's very important to work with the oncology team and to take each individual circumstance into account. There is perhaps some value in looking at the hormone receptor status, but it doesn't carry the same value as breast cancer hormone receptor status does. And so we still have to be mindful that we need to take other factors into consideration in making a decision whether to prescribe. So we take into account, the stage of the malignancy, the age of the patient, whether there's osteoporosis, how symptomatic they are, the usual things that I'm sure that our audience would ask our patients about in making an overall decision, weighing up the benefits and risks.
And similar to that, I answered one of the questions on triple negative breast cancer. How do you feel about that?
Look, all breast cancer, according to summary of product characteristics, is an exclusion criterion or contraindication to hormone therapy. Having said that, I would feel more comfortable prescribing to somebody with a triple neg breast cancer, but I would caution that their chances of developing a hormone receptor positive breast cancer because of their prior diagnosis is increased, and therefore we cannot say that it is an entirely safe practice. And again, the issues that I've described regarding prescribing with ovarian cancer also apply to that scenario as well.
And that would perhaps be a consideration for one of these newer therapies for vasomotor symptoms as well, Nick, as well as obviously great caution about the lowest effective dose for symptom control in that situation. But I guess you're really alluding to some of the more long-term risks for that rather than just symptom control, aren't you, which is the challenge in these younger patients when they might only be 30 and potentially have 60 or 70 years of life ahead of them.
Absolutely. It's about considering prescribing from the whole armamentarium. As you say, these new treatments provide us with an exciting new option for women where they have predominantly vasomotor symptoms. But with POI, we have the longer term concerns about bones, heart, and brain health. So we need to take that into consideration as well.
Yeah, absolutely. That's the interesting thing about this group of women is also the prescriptions we give are very long term. And so safety is really important. But our goals are additional to the menopausal age group, as you mentioned, in terms of prevention. So
Indeed.
thanks so much for everybody who stayed on. We have over 300 people who stayed on and about 460 at the peak of the discussion today. And this will be available afterwards online, this recording. And I'd just like to say a couple of things about IMS, and that is these are many of the things that we do in IMS. It's a great organization. I would encourage you to go to our website to find out more about the many educational events and resources that you see listed here. And becoming an IMS member, you will receive exclusive offers. You get a free 1-year IMS membership with completion of Impart Level 1. And also we have partnerships with local and regional societies who are also members of CAMS, which is the local menopause societies that are found in, I think it's over 90 countries now around the world. There are also monthly live events, an extensive library of educational resources, and you can find out more at www.imsociety.org. We really thank you for your collaboration and time, and I remain available. And again, I think Nick and Richard would be for any need or question you may have. Thank you very much today.
Thank you very much, everyone. Thank you, Wendy. Thank you, Richard.
Thanks a lot, Nick. Thanks, Richard.